Welcome back to the deep dive. Today, we're taking that just overwhelming flow of acute medical information and really trying to distill it down.
We are. We're focusing on the crucial life-saving knowledge you need to anchor your understanding, especially when you're just starting out in your clinical training.
And today, we are undertaking a deep dive into an area of acute medicine that is, well, it's both incredibly common and, frankly, terrifying. Poisoning.
And this isn't some niche topic you'll only see in a specialized center. The data really confirms this is high-stakes medicine. Acute poisoning accounts for about 1% of all hospital admissions in the UK.
1%. That's a huge number.
It is. And globally, it is tragically still a leading cause of death in young adults.
And the nature of this threat, it really changes dramatically depending on where you're practicing. We're drawing heavily on the structured approach you find in Davidson's medicine.
Yes, and it shows a really stark global disparity. In high-income countries, we often focus on intentional self-harm, usually involving prescribed medications or things you can get over the counter.
Right, the stuff people have in their medicine cabinets.
Exactly. But if we look at lower-income regions, the focus shifts drastically. We see massive fatality incidents, often involving agricultural chemicals, specifically high-fatality pesticides.
We're talking about places like China and Southeast Asia.
Precisely. You have situations where the sheer number of suicides involving these agents accounts for, well, hundreds of thousands of deaths every year. It's a public health crisis that demands a very specific approach, which we'll definitely revisit when we get to organophosphates.
So our mission today is to give you, the medical student, a structured approach. We want to cut through all that noise, give you some solid memory anchors, and highlight the most critical, life-saving knowledge.
The goal is to get you from that state of, informational panic to a place where you can provide effective initial management. We're going to tackle this using the framework of the toxicology funnel.
Before we jump into that funnel, let's just briefly touch on the causes.
Right. We generally classify them into a few buckets. There's intentional self-harm, which is the most common reason for acute admissions. Then you have accidental poisonings.
Like with kids or maybe the elderly.
Exactly. Then there's recreational misuse, and finally, environmental or occupational exposure. But, and this is the key point, regardless of how it happened, the very first steps are always about stabilization.
Right. So let's start at the top of that toxicology funnel, the general approach to the poison patient.
The whole idea of the funnel is it's just beautiful in its simplicity. You start really broad, focusing on the immediate threat to life, and then you rapidly narrow down your focus to the specific diagnosis and management.
So first things first, triage and resuscitation.
Yes. The foundational concept here, the thing that dictates every single action in the first 10 minutes, is that early identification of serious poisoning is absolutely paramount.
Triage is all about speed and safety.
It is. You are doing three things at once: stabilizing the patient, trying to identify the poison, and removing any immediate hazards, especially if there's external contamination.
And the anchor here is just non-negotiable, isn't it? It's ABCs first, always.
Always. Start with the airway, make sure breathing is adequate, check the respiratory rate, the oxygen saturation, and then check circulation, pulse, blood pressure, looking for any dysrhythmias.
A critically ill patient can't wait for you to get a full history or for the tox screen to come back.
Absolutely not. If the patient is unstable, you are in immediate resuscitation mode. Full stop.
And what about consciousness? Assessing their neurological status.
So important.
Yeah.
While the Glasgow Coma Scale, the GCS, is, the gold standard, in the chaos of a busy emergency department, the simple AVPU scale is so much faster.
Alert, verbal, painful, unresponsive.
Exactly. It gives you rapid, crucial information on how depressed their central nervous system is. A patient who is only responsive to pain or is unresponsive, that patient needs immediate airway attention.
We also can't overstate the importance of the cardiotoxicity check.
Oh, definitely not. If you have even the slightest suspicion of a cardiotoxic substance, and that list is long, it includes TCAs, beta blockers, digoxin, or if the patient has any cardiovascular symptoms.
You need an ECG immediately.
Immediately.
Yeah.
And not just a one-off ECG. You need continuous cardiac monitoring. This is so critical because some of the most lethal ingestions kill by causing immediate cardiac instability. It overrides everything else.
So the key takeaway for this first phase is that triage is about doing things at the same time.
Yes. Stabilize the ABCs, Figure out if there's an external hazard like a chemical spill or powder on their clothes, and start decontaminating the exterior while the resuscitation is happening. Your speed here often determines survival.
Okay, so once stabilization is underway, we can move into the next part of the funnel, clinical assessment, the history on.
And we have to acknowledge a tough reality here. The history you get is often going to be incomplete or just unreliable.
The patient might be confused or not know what they took or even be actively misleading.
Which is why we rely on a standardized checklist. You have to ask what toxin or toxins, how much, when, by what route, and importantly, what about co-ingestions, alcohol, other drugs.
You also need details from any witnesses, the patient's past medical history.
And for an intentional overdose, a suicide risk assessment is essential. Plus, you have to determine their capacity to refuse care. You should always, always assume it's a multi-drug exposure until you can prove otherwise.
And this is where the physical exam comes in. The clinical clues start to point you in the right direction.
Right. Davidson's has a fantastic head-to-toe checklist. You're looking for subtle things. Is there a tremor? Muscle fasciculations? You're listening to the chest for signs of aspiration or bronchoconstriction, checking their reflexes.
And paying close attention to the abdomen.
Specifically, you need to check for right upper quadrant or renal angle tenderness. That can be an early clinical sign of paracetamol hepatotoxicity or maybe renal toxicity from something like ethylene glycol.
And you're also looking for that physical evidence, needle tracks, self-cutting marks.
Or chemical burns on the skin or around the mouth.
But I think the most powerful tool in the toxicology arsenal is pattern recognition, which brings us to a huge memory anchor, toxidromes.
Yes. Toxidromes are these distinct clusters of clinical signs, changes in pupils, heart rate, temperature, mental status, that strongly suggest a class of drug long before you get any lab confirmation.
We're focusing on 5 main clusters, right?
Right. Anticholinergic, serotoninergic, stimulant, sedative hypnotic, and opioid, plus the cholinergic syndrome, which we'll cover later.
So let's run through some of those key signs that give you that instant differentiation.
Okay, let's start with the pupils. If they are fixed and pinpoint small meiosis, you have to be thinking opioids, organophosphates, or maybe clonidine.
And if they're the opposite, wide and dilated mydriasis.
Then you're looking at things like TCAs, amphetamines, or cocaine.
What about temperature and skin?
If the patient is hot, so hyperthermic and sweating, that strongly suggests a stimulant like cocaine or MDMA or maybe salicylates.
But if they're hot and their skin is dry and flushed,
that points you straight to the anticholinergic toxidrome. Think TCAs, antihistamines. On the other hand, hypothermia usually means heavy CNS depression, like from benzodiazepines or opioids.
And finally, heart rate.
Tachycardia, a fast heart rate, suggests TCAs, theophylline, or stimulants. Bradycardia, a slow heart rate, suggests some really lethal agents like digoxin, beta blockers, calcium channel blockers, or opioids.
That pattern matching is what lets you leapfrog the differential diagnosis. It's not just academic, it dictates your next move.
Absolutely. It tells you whether to grab a life-saving antidote or start aggressive cooling protocols.
Okay, so that leads us into investigations.
Right. Routine labs start with ureas, electrolytes, and creatinine in the UEC. But if you have any concern about their breathing or circulation, or you suspect a substance that messes with metabolism,
you need arterial blood gases and ABG.
Immediately. It's essential to assess their oxygenation and, crucially, their acid-base status.
And this is where we bring in the metabolic detectives, the anion gap and the osmolar gap.
For medical students, these gaps are just the purest form of chemical pattern matching in toxicology. They're so powerful.
Let's define them clearly. The anion gap.
So the calculation is your sodium minus the sum of your chloride and bicarbonate. An elevated gap, usually anything over 16, means there are unmeasured acid anions floating around in the blood.
And you must memorize the toxic causes. There are mnemonics for this.
You have to. The big ones are salicylates, methanol, ethylene glycol, iron, and cyanide.
And then we have the osmolar gap.
This is the difference between the measured osmolality from the lab and the calculated osmolality. You calculate it using sodium, urea, and glucose.
And a gap over 10 is significant.
Right, it means there's a significant concentration of some unmeasured osmotically active substance. And the mnemonic for toxic causes here is the MEE triad: methanol, ethylene glycol, and ethanol.
The clinical magic happens when you connect these two gaps, right?
Yeah.
Especially for the toxic alcohols.
Exactly. Methanol and ethylene glycol start off with a high osmolar gap because the parent drugs themselves are osmolar. But as they get metabolized by alcohol, dehydrogenase into their toxic acids.
The parent alcohol gets used up, the OG closes, and the Antanian gap starts to climb.
And it climbs rapidly because of the metabolic acidosis.
Yeah.
That time-dependent shift is the key diagnostic feature you're looking for.
We should also quickly distinguish the causes of acidosis. Some produce normal lactate, some high lactate.
Right. Salicylates and the toxic alcohols, at least early on, will give you an acidosis with a normal lactate.
Yeah.
But things like metformin, iron, cyanide, or carbon monoxide, where tissue hypoxia is the main problem, will give you a high lactate.
Okay, a quick note on methemoglobinemia before we move on.
Yes, this is a condition caused by potent oxidizing agents like dapsone or nitrites. They change the iron in hemoglobin from the normal Fe2 plus state to the Fe3 plus state.
So what does that look like clinically?
The patient looks cyanotic, sort of blue, but they don't respond to supplemental oxygen. That's because the hemoglobin literally cannot bind oxygen effectively.
And the treatment is very specific.
Very specific and life-saving. It's the reducing agent methylphenidinium chloride, which you probably know as methylene blue.
Okay, let's pause there and anchor this pattern recognition. This is a critical clinical skill.
So let's run a quick scenario. A 25-year-old patient is brought in unconscious. You've sorted their ABCs, but they have a temperature of 39.5 degrees Celsius. Their heart rate is 140, and their pupils are fixed and fully dilated.
So using that triad fever, tachycardia, dilated pupils, what two toxidromes must immediately be at the top of your differential diagnosis?
The two primary culprits there would be the stimulant toxidrome or the anticholinergic toxidrome.
Exactly, and the clinical differentiator is crucial. If their skin is dry, hot, and flushed,
You're leaning towards anticholinergic.
and if they're sweating profusely and agitated,
Then you are deep in the stimulant realm. And that immediate recognition helps you anticipate the big complications: arrhythmias, seizures, and a hyperthermic crisis.
right. If you didn't get those two immediately, rewind and just listen to that bit on toxidromes again before moving on.
Definitely.
Okay, so now we're moving from diagnosis to intervention. We've stabilized the patient. We think we know the toxin. Now we need to get it out.
So decontamination and elimination.
Starting with external decontamination.
This is absolutely non-negotiable for things like corrosive chemicals or pesticides.
Yeah.
For eye contact, you need to irrigate continuously for at least 15 minutes with saline or water. And remember to get contact lenses out immediately.
And for skin contact,
Remove all their clothing, because it could be contaminated, and wash the area with tons of soap and water. And importantly, healthcare providers have to protect themselves here too.
now for internal decontamination. The classic intervention, activated charcoal. We call it the toxic sponge.
It's a great metaphor. It has this massive surface area that allows it to absorb toxins inside the bowel. It's most effective within 1 hour of ingestion, but it can still be useful later for delayed release pills or if something else has slowed down gastric emptying.
But we have to talk about the risks.
The single biggest risk is aspiration pneumonitis. It's huge.
Yeah.
If the patient has a reduced level of consciousness, you must secure their airway, usually with a cuffed endotracheal tube, before you give them charcoal.
And here is the essential memory anchor for exams and for real life. The list of substances that are poorly absorbed by charcoal.
This is the list that always catches people out. You have to memorize it. It's iron, lithium, acids, alcohols like ethanol, methanol, ethylene glycol, and petroleum distillates.
Okay, since those are such huge exceptions, let's tackle them right now. Let's start with iron and lithium.
Good idea. Iron toxicity is a high-stakes, fast-moving emergency. Charcoal does absolutely nothing, so you have to pivot your treatment immediately.
What's the move?
If it's a severe acute ingestion, you might start whole bowel irrigation early on to just flush out unabsorbed tablets, but the definitive move is the antidote, desferrioxamine, which is a chelating agent.
And you can't wait for labs.
You cannot. If the patient presents with severe features, shock, coma, metabolic acidosis, you start the desferrioxamine immediately. You don't wait for the serum iron level to come back. Time is visceral here.
And lithium is a similar story, another charcoal failure.
Yes, toxicity is often seen in chronic users who get dehydrated or start taking an interacting drug. Again, charcoal is useless. Management is about aggressive hydration and maybe whole bowel irrigation.
But the definitive treatment for severe toxicity is
Hemodialysis. It's incredibly effective at clearing lithium from the blood. And you need to know the cutoffs. For acute poisoning, a level above 7.5 millibel generally means immediate dialysis.
So by anchoring iron and lithium right here, you create this dedicated memory block for the charcoal exceptions.
Exactly. Okay, so back to charcoal. There's also multiple dose activated charcoal, or MDAC.
Sometimes called gastrointestinal dialysis.
It's a specialized technique used for a small list of highly toxic drugs, even hours after ingestion. The mechanism is really brilliant. By giving charcoal continuously, you disrupt the enterohepatic circulation of certain drugs.
And you create a concentration gradient.
Exactly. It promotes the drug's diffusion out of the blood, across the gut wall, and back into the gut, where the charcoal can bind it and get it eliminated. It acts like a sink.
And this works for which drugs?
It's effective for carbamazepine, dapsone, phenobarbital, and theophylline.
What about the really old school stuff like gastric lavage, pumping the stomach?
Extremely rare now. The risk of complications, especially aspiration, is massive. And the data shows it's usually no better than just giving charcoal. And it is absolutely contraindicated for corrosives or petroleum products. High risk of perforation.
Okay, and lastly, whole bowel irrigation, WBI, which we mentioned.
Right. This is where you give large volumes of a polyethylene glycol solution, a PEG solution, through an NG tube until the rectal effluent runs clear.
And we use this for the things charcoal doesn't bind, like iron and lithium.
And also for body packers. Patients who've swallowed packages of illicit drugs, you need to clear them fast to prevent a catastrophic rupture.
So if decontamination isn't an option or the toxin is already absorbed, we turn to enhanced elimination, pushing the toxins out.
First up is urinary alkalinization.
This is pure chemistry, right?
It is. It relies on chemical kinetics, and it's used for weak acids, most commonly salicylates and methotrexate. You infuse sodium bicarbonate to get the urine pH above 7.5.
And what does that do?
That alkaline pH ionizes the drug. Once it's ionized, it's trapped in the urine because it can't diffuse back across the renal tubules. This dramatically increases how much is excreted.
But it's a balancing act.
Real clinical tightrope. You have to watch for complications like alkalemia and especially hypokalemia.
The next stage is mechanical removal, hemodialysis, and hemoperfusion.
These are reserved for life-threatening toxicity. For hemodialysis to work, the toxin needs to have a small volume of distribution, meaning it stays in the blood, and a long half-life. And it has to be small enough to cross the dialysis membrane.
The HDHP list is another one of those high-yield anchors to memorize.
For sure. HD is the treatment of choice for the toxic alcohols, ethylene glycol and methanol plus salicylates and lithium. HP, which uses a charcoal filter, works well for things like theophylline and carbamazepine.
And finally, a really fascinating strategy, lipid emulsion therapy.
The lipid sink. It's a perfect metaphor. You give a 20% intravenous lipid emulsion, which creates this massive pool of fat droplets in the blood.
And the lipid-soluble toxins get drawn into it.
Exactly. They partition into these fat droplets, which sequesters the drug and reduces the free concentration of the toxin at its target sites, like the heart and the brain.
The best evidence is for local anesthetic toxicity, like from bupivacaine.
It is, but its use has expanded. There's anecdotal success for other highly lipid-soluble cardiotoxins, TCAs, some calcium channel blockers, and lipophilic beta blockers like propranolol.
Okay, so that brings us to antidotes and supportive care.
Right, antidotes are the stars of toxicology, but it's essential to understand how they work, not just their names. The source material breaks them down into 4 brilliant categories.
Go ahead.
First, you have receptor antagonists. They just block the toxin at the receptor. Think naloxone for opioids or atropine for organophosphates.
Okay.
Second, enzyme effects. These either fix a deficiency or reactivate an enzyme. The classic example is acetylcysteine for paracetamol, which replenishes your glutathione reserves.
Third,
inhibiting toxic metabolite formation. So this is the whole game with methanol and ethylene glycol. Fomepizole blocks alcohol dehydrogenase, so the toxic acids never get made.
and the last one?
Binding agents. These chelator bind the toxin in the blood to stop it from getting to the target organ. So, dysferrioxamine for iron or hydroxycobalamin for cyanide?
Antidotes are critical, but here's the cold, hard truth. For most poisonings, there is no specific antidote.
And that's where supportive care comes in. Tireless, appropriate nursing, and aggressive management of complications, that's what dictates the outcome for the majority of patients.
Let's run through the management of those key complications. Coma.
Airway protection first, always, plus rigorous pressure area and bladder care. IV benzodiazepines are your first line, usually lorazepam, and you have to correct any underlying hypoxia or metabolic issues.
Hypotension.
Start with aggressive IV fluids. If that doesn't work, you move to vasopressors.
And the big one, cardiotoxicity. This requires really precise, pattern-based treatment.
Absolutely. If you see ventricular tachycardia with a really prolonged QRS interval, that tells you it's sodium channel blockade. The key treatment is IV sodium bicarbonate.
And if you see torsades de pointes, which is associated with a prolonged QTC interval,
That's potassium channel blockade, and the key treatment is IV magnesium sulfate.
that distinction, QRS versus QTC, is the clinical differentiator that changes your immediate drug order. Let's make sure that's anchored.
Okay, so imagine you have a patient unconscious and hypotensive from an unknown overdose. You put them on the monitor, and the rhythm is fast, but the QRS complex is, wide say, greater than 0.16 seconds.
Based purely on that ECG, what immediate intervention should you prepare and what class of meds does that scream?
The wide QRS confirms severe sodium channel blockade. The immediate life-saving treatment is IV sodium bicarbonate, and it strongly suggests poisoning by a sodium channel blocker, most commonly a tricyclic antidepressant, a TCA.
And the bicarbonate works by correcting acidosis and also by providing a huge sodium load to just override the blocked channels.
Precisely. That's the level of rapid decision-making you need in toxicology.
Okay, let's dive into some specific agents now, starting with the most common pharmaceutical poisons.
Analgesics first. Paracetamol and salicylates.
Paracetamol, or acetaminophen, is the #1 drug in overdose in many places. The mechanism is like a tragic chemical titration.
It is. The toxic metabolite, NAPQI, is usually rendered harmless by the liver's protector glutathione, the bodyguard.
But in a massive overdose, the glutathione runs out.
Exactly. The reserves are exhausted, NAPQI builds up, and it starts binding to liver cells, causing massive hepatocellular necrosis and acute liver failure.
Management starts with activated charcoal if they present within an hour. But the core treatment is the antidote, acetylcysteine.
It acts as a precursor to glutathione, basically replenishing those depleted bodyguard reserves. The treatment dose and duration are guided by the paracetamol nomogram for single acute ingestions.
Okay, here's the absolute critical clinical point that can't be stressed enough.
If the patient presents more than 8 hours after ingestion, you must not delay treatment. The effectiveness of acetylcysteine drops off a cliff after that 8-hour mark.
So you start the infusion immediately, even while you're waiting for the paracetamol level to come back.
Yes. Delay equals liver failure. Simple as that. A key side effect to watch for is the non-allergic anaphylactoid reaction histamine release causing a rash or flushing, which you can usually manage by slowing the infusion.
Okay, moving on to salicylates. Aspirin.
The clinical features are pretty recognizable. Nausea, vomiting, ringing in the ears, tinnitus, and deafness. They also hyperventilate from central stimulation, which can cause an early respiratory alkalosis.
But severe cases progress to a life-threatening metabolic acidosis.
They do, along with shock and cerebral edema. And the core physiological anchor for salicylate toxicity is that toxicity is enhanced by acidosis.
What is that?
Acidosis promotes the non-ionized form of salicylate, which is highly lipid-soluble. This allows the toxin to cross the blood-brain barrier much more easily, causing severe neurotoxicity, seizures, and coma. So correcting the acidosis is everything.
So management.
Activated charcoal early on. But the main specific intervention is urinary alkalinization for moderate to severe poisoning. You want to trap that ionized salicylate in the urine.
And for very severe poisoning.
For concentrations over 700 milligl or any signs of coma or refractory acidosis, hemodialysis is the definitive treatment. It's incredibly effective, removing the toxin and correcting the acid-base disturbance at the same time.
And a quick note on NSAIDs.
Generally low toxicity. They'll cause some mild GI upset. If a patient is asymptomatic 6 hours after an overdose, they're unlikely to develop problems.
Okay, let's move to antidepressants, TCAs, SSRIs, and lithium.
Tricyclic antidepressants, TCAs, are extremely dangerous in overdoses. We already touched on the life-threatening cardiotoxicity.
The 3 major toxic effects are sodium channel blockade,
Potent anticholinergic effects, dry mouth, dilated pupils, delirium, and alpha-adrenoceptor blockade, which causes severe refractory hypotension.
and again, the ECG is your crystal ball. A QRS longer than 0.16 seconds is a huge red flag for arrhythmia risk.
And the treatment is IV sodium bicarbonate. You're treating the acidosis, yes, but you're also flooding the system with sodium ions to outcompete the TCA at the sodium channel, restoring normal conduction.
SSRIs and SNRIs are generally safer, but the key risk is serotonin syndrome.
Right, especially when co-ingested with other serotonergic agents like MDMA or tramadol.
And serotonin syndrome is distinct from the anticholinergic toxidrome.
Very distinct. You're looking for a triad of mental status change, like agitation, autonomic hyperactivity fever, tachycardia, and neuromuscular abnormalities like shivering, tremor, and myoclonus. The muscle activity is hyperreflexic, often with clonus.
And management is largely supportive.
It is cooling and benzodiazepines for sedation and muscle relaxation.
And lithium, which we already covered as a charcoal failure.
Right. Toxicity often creeps up in chronic users when their renal function declines. The clinical picture progresses from tremor and GI upset to severe neurological features like seizures and coma. And the definitive management for severe cases remains hemodialysis.
Okay, next up, cardiovascular medications.
These agents are highly lethal because they hit the body's fundamental pump function. Beta blockers cause severe bradycardia, hypotension, and heart block.
And some have specific effects. Propranolol blocks sodium channels, risking seizures.
And sotalol blocks potassium channels, which can cause QTc prolongation and torsades de pointe.
Standard management after atropine centers on two big interventions. First, glucagon.
Right. Glucagon bypasses the blocked beta receptors and stimulates intracellular KMP production directly, which improves heart muscle contractility.
And for severe refractory shock, we use hyperinsulinemia euglycemic therapy, or HIET.
Yes, which is also the cornerstone of treating calcium channel blocker toxicity.
CCBs are brutally toxic in overdoses. Profound hypotension, bradycardia, heart block.
And critically, they also cause hyperglycemia and metabolic acidosis.
Management starts with IV fluids and IV calcium gluconate. But for refractory shock, it's HIET.
It's the most successful strategy.
Let's break down the rationale for height. It sounds so counterintuitive. Why give massive amounts of insulin to a patient who's already hyperglycemic?
It's a physiological rescue. CCB overdose causes a state of hypoinsulinemia and generalized insulin resistance. The failing heart muscle is starved for high-efficiency fuel.
So the high-dose insulin forces glucose into the heart cells.
Exactly. It drives glucose into the myocardial cells and improves the heart's use of that glucose, optimizing energy delivery and rapidly improving contractility. It's treating the metabolic dysfunction, not just the blood pressure.
Okay, that makes perfect sense. Let's anchor this. In severe CCB overdose, why is hyperglycemia a defining clinical feature, and how does HIET use insulin to treat the heart?
Hyperglycemia is a result of the CCB-induced hypoinsulinemia and insulin resistance. HEA uses those massive doses of insulin, along with glucose, to bypass that resistance, forcing glucose uptake and efficient use by the stressed heart muscle, giving it crucial metabolic support.
Perfect. And lastly for this section, digoxin.
The classic exam-worthy arrhythmia is atrial tachycardia with AV block. You'll often see hyperkalemia. For severe refractory arrhythmias, the definitive antidote is digoxin-specific antibody fragments, FAB.
Okay, now let's move into drugs of misuse. Here we really rely on those toxidrome patterns we discussed.
Heavily, especially with all the new psychoactive substances where you often have no idea what's actually in them.
So let's start with depressants, opioids, and benzodiazepines.
Opioids, heroin, fentanyl, methadone present with that classic triad. Reduced respiratory rate, depressed mental status, and characteristic miosis, or pinpoint pupils.
And methadone has the added cardiac risk.
Yes, QTc prolongation and torsades.
Critical management is the rapid administration of the antagonist naloxone.
But the clinical detail that saves lives here is that naloxone has a short half-life. It's often much shorter than the opioid the person took, especially something long-acting like methadone.
So the patient can wake up and then crash back into respiratory depression an hour later.
Exactly. It's a huge pitfall. You have to give repeat doses or start a continuous infusion, and you must monitor them closely for a minimum of 6 hours after the last dose of naloxone.
What about benzodiazepines?
Benzos alone have relatively low toxicity, but they are lethal potentiators. When you mix them with alcohol or opioids, they profoundly worsen CNS and respiratory depression.
There is a specific antagonist, flumazenil.
There is, but its use comes with a huge flashing warning sign. It carries a high risk of precipitating seizures, especially if the patient also took any proconvulsants like TCAs or cocaine.
You don't want to trade a sleepy patient for a seizing patient.
Never.
Okay, moving on to stimulants.
The stimulant toxidrome is that classic sympathetic storm. Tachycardia, hypertension, hypothermia, extreme restlessness, and mydriasis, dilated pupils.
Cocaine toxicity is purely sympathomimetic. Life-threatening complications like MI or arrhythmias usually happen within 3 hours.
You have to consider it in any young adult who comes in with unexplained chest pain.
Management is about calming the storm.
It is, primarily with benzodiazepines to control agitation and lower blood pressure, 4V nitrates for chest pain, and aggressive physical cooling for hyperthermia.
And here is the key clinical caution.
Beta blockers may be contraindicated. Blocking the beta receptors can leave the alpha receptors unopposed, which can cause paradoxical, severe vasoconstriction, making everything worse.
And what about amphetamines like MDMA?
They have the stimulant effects, but also significant serotonergic activity. A specific anchor point for MDMA or ecstasy is hyponatremia from a combination of SIADH and excessive water drinking. Management is supportive, focusing on the hyperthermia and electrolyte problems.
Okay, a brief run through hallucinogens and dissociatives.
Right. Synthetic cannabinoids, spice, are highly unpredictable and can cause severe agitation and seizures, very different from natural cannabis. Management is purely supportive.
Tryptamines like magic mushrooms?
They're serotonin agonists. The big risk is combining them with other serotonergic drugs and triggering serotonin syndrome.
And LSD.
Management is often non-pharmacological, a quiet, dark, non-stimulating environment. Benzodiazepines are the drug of choice for severe agitation. And you must avoid antipsychotics, which can cause cardiovascular collapse in this setting.
And finally, ketamine.
The long-term toxicity is distinct and devastating. Chronic use causes a severe, painful chronic cystitis.
Okay, our final section, chemicals, pesticides, and the environment. These are high-risk, high-fatality agents.
And speed of antidote administration is everything.
Let's start with carbon monoxide, COO, the silent killer.
Colorless, odorless, its toxicity is twofold. It binds to hemoglobin 250 times more tightly than oxygen, and it also directly inhibits cytochrome oxidase, which cripples cellular respiration.
Early features are notoriously vague.
Headache, nausea, so it's often missed. Severe poisoning leads to coma, seizures, and often long-term neuropsychiatric problems. Management is immediate removal from exposure and high-concentration oxygen.
Which drastically reduces the COHB half-life.
From 4-6 hours down to about 40 minutes. Hyperbaric oxygen is still a bit controversial, but it's used in severe cases.
Now, let's return to that global health crisis, organophosphorus compounds, or OPs.
Used as pesticides and nerve agents, they have an extremely high fatality rate, a major toxicological emergency worldwide.
And the mechanism is the anchor, the enzyme lockup.
OPs inactivate the enzyme acetylcholinesterase, or ACE. This leads to a massive, life-threatening buildup of the neurotransmitter acetylcholine.
And we have to understand the concept of aging.
Yes. Initially, the OPHE bond is reversible, but over minutes to hours it becomes permanent. The enzyme is aged and permanently inactivated. The body has to synthesize brand new enzyme, which takes days.
And the clinical result is the acute cholinergic syndrome.
Right. You get muscarinic effects, the SLDGE mnemonic, salivation, lacrimation, urination, diarrhea, GI upset, emesis, plus bradycardia and severe bronchoconstriction. And you get nicotinic effects, muscle fasciculations leading to weakness and paralysis, including respiratory muscles.
Management has to be aggressive.
First, and life-saving, is atropine to reverse the muscarinic effects, drying secretions, increasing heart rate. Second, you use oximes, like pralidoxim,
Which reactivate the enzyme.
but only if you give them before aging happens.
Okay, let's move on to the toxic alcohols and glycols.
Methanol and ethylene glycol, a fascinating pair. Neither is intrinsically toxic. The threat comes from the enzyme alcohol dehydrogenase, which converts them into highly toxic acidic metabolites.
Methanol's breakdown product, formic acid, causes blindness.
And ethylene glycol's metabolites cause acute kidney failure from calcium oxalate crystals.
Diagnosis is all about the metabolic picture.
Right.
A high osmolar gap at first, followed by a massive high anion gap and severe metabolic acidosis.
And the critical management is the antidote competition. You have to stop that metabolism. You give either fomepizole, which is preferred, or ethanol.
And they both competitively block alcohol dehydrogenase.
Exactly. They stop the creation of the deadly metabolites until the parent drug can be cleared, which is usually done with hemodialysis.
Okay, just a couple more. Corrosives and metals.
Corrosive substances, acids, and alkalis cause immediate GI pain, ulceration, and risk of perforation. The management rules here are firm. NO gastric lavage. And NO neutralizing chemicals because the heat from the reaction causes more damage.
And iron, we've covered. Charcoal is useless, and you need dysferrioxamine immediately in severe cases.
Right. And just briefly on chemical warfare agents, nerve agents are treated with atropine and oximes. Blood agents like cyanide need specific binding antidotes like hydroxycobalamin.
Okay, that was an incredibly dense deep dive. Let's distill this down into the 5 most critical takeaways, the ultimate med student shortlist.
Number 1. Always stabilize the patient ABCs before you seek the diagnosis. Resuscitation comes first.
Number 2, Use toxidromes and the antinosmolar gaps as your immediate diagnostic guides. They are your pattern recognition tools.
3. Know the toxic sponge limitations. Activated charcoal is useless for iron, lithium, and the alcohols.
Number 4. The ECG is your guide for cardiotoxins. Wide QRS means 5V sodium bicarbonate. Long QTC means IV magnesium sulfate.
And number 5. Antidotal timing is crucial. Don't delay acetylcysteine for paracetamol. Remember naloxone's short half-life for opioids. And give atropine first for organophosphates.
We've spent a lot of time on the glamorous, fast-acting antidotes.
We have. But the underlying message, the real core truth of toxicology, is that for the vast majority of poisons, survival hinges not on a specific antidote, but on tireless, fundamental supportive care.
So your mastery of basic critical care, protecting the airway, managing seizures, correcting shock, that's what keeps the patient alive long enough for their body to clear the toxin.
Absolutely. It highlights that no matter how obscure the toxin, your foundational skills in critical care are the single most important asset you have.
It's a humbling thought. The basics often save the day.
Good luck applying this knowledge, and keep diving deep into the fundamentals.